No, it's so weird. It's a secret organization. It will not even tell you what PEO stands for. I have no idea. Nope. It's women owned PEO. It funds women in academics. So.
Okay, it's my pleasure to be able to introduce Dr. Almandoz. He's a professor of medicine and medical director of the Weight, Wellness, Obesity Medicine program at UT Southwestern Medical Center, board certified in endocrinology, internal medicine, and obesity medicine. He did his medical degree in Ireland and a residency there. And then he followed this up with a residency and a fellowship at the Mayo Clinic, and then did another fellowship when he went to UT Southwestern Medical Center. His clinical and academic work centers on comprehensive obesity care, integrating nutrition and lifestyle, advancing health equity, and improving long-term outcomes in bariatric surgery. He's been consistently funded by NIH, has been invited as an invited speaker both nationally and internationally. He serves on the board of directors of the American Board of Obesity Medicine and is Obesity Society 2025 Clinician of the Year. I'd like to.
Thanks so much for the kind introduction, and thank you again for the invitation to be here. I've had a wonderful time visiting with everyone and learning about what you guys are doing here, and it's absolutely phenomenal. Thanks for the great weather too. It's been phenomenal. So I'm not a researcher. I kind of cosplay as a physician scientist, and so don't call me out. But what I want to do is kind of highlight how my real world clinical experience and what I do in the research sphere informs kind of the practice of what we do at multiple levels, including our major accreditation body for obesity medicine, my role at ABOM, but also what I see is kind of the real world gaps that I kind of hear from patients every day. I collaborate with a lot of industry partners and have uncompensated roles within different organizations. And so kind of looking at kind of the current limitations of kind of what obesity care is there, looking at biological, behavioral, and clinical factors influence weight gain, long-term outcomes. And these are kind of what I'm going to talk about today, but let's just get to the meat, okay? Let's frame, can you guys hear? So framing the issues, we have GLP-1 therapies that are really highly effective, yet biology drives a lot of recurrence after discontinuation. And discontinuation happens for a lot of different reasons that we'll touch on. Responses vary across weight, kind of metabolic health and function during therapy, and of course, also after stopping. And lifestyle is essential for sustaining health outcomes on and off of therapy. And these are givens, but there's not something that the public who's yearning for treatment with GLP-1s or the clinicians providing it actually operationalize on a daily basis. And I think the question is, what do we need to do to implement the things that we know are effective? Well, when we look at kind of treatment life cycle and obesity care, there's kind of strong evidence for initiation practices, for patient selection, treatment selection, whether or not that translates into access and affordability, and prescribing practices. That's a whole nother thing altogether. In terms of optimization and dose strategy and titration and how to help with tolerability, that's evolving as well, and we're working on that, and we have good evidence with regards to what works and what doesn't. From a maintenance perspective, this is when it starts to get a little dicey and the traffic lights start to change. It's what does that look like? Patients are like, well, do I need to take this forever? When can I stop this? Clinicians are saying, well, their weight's come down, blood pressure looks good, we're going to stop this, right? And we really know that that's not the right thing to do. But how do we then demonstrate that it is the right thing to do consistently in a way that demonstrates value to the people paying it, to the people taking it, and for society who have an opinion that patients taking these medications listen to? And I think that's to say that there's a multifaceted challenge with regards to treatment persistence and adherence for something we know is quite effective. And once there's discontinuation, if there should be discontinuation, what does that look like? Do we stop at cold turkey, like registration trials, and just watch the weight like slingshot back up? Do we just have some kind of tapering or microdosing thing? Do we switch them to a different medication and conflate, well, it's still a GLP, so maybe this works, or let's try some phentermine, and if they keep the weight off, then the health benefits will be maintained. I think these are really challenging when we don't have data and we have a lot of force switching and discontinuation in the real world that is really difficult to translate into action. We are fortunate to have several FDA-approved obesity medications which work in different ways at different levels. And so we have lipase inhibitors like orlistat that make you malabsorb about 30% of the fat you put in. So you can imagine it's quite difficult to convince a patient to take a second dose, right? There's phentermine, which is the house wine for most people who go to primary care or their OBGYN to talk about weight management, because this is what generations of primary care focused clinicians have been told. This is cheap, it's affordable, you can get it for $4 to $10 per month with no insurance. But for people who have higher cardiometabolic burden, does it make sense for someone with hypertension, on three agents, plus a history of heart attack or stroke to take a high dose amphetamine? Probably not. But if it's what's there, and we think, well, if they lose weight, everything's going to get better, that then becomes an interesting value proposition for clinicians. Naltrexone and bupropion is one of the more kind of modest weight loss losing medications, but given the role it has in where we stole it from, addiction psychiatry, and its role in altering hedonic drive for consumption and other things, it may have a specific role for addressing symptoms of obesity. As we start to think of obesity as a chronic disease where there are signs that could be body mass or adiposity in certain areas versus symptoms that include food noise, appetite, and cravings, how are we comprehensively addressing disease beyond looking or conflating weight outcomes with successful treatment? We have the meat here, which is the GLP and GIP dual receptor agonists, and these are what's currently approved. We initially had daily liraglutide, followed by semaglutide, both injectable and now oral, tirzepatide, dual agonist, GLP, GIP, and most recently orforglipron, small molecule GLP-1 agent. And so we have a variety of different agents that also work very differently. For years, we've tried to kind of bridge this gap between lifestyle modification and bariatric range weight loss for a variety of different reasons, including patient preference for a magnitude of weight loss that often exceeded the tools we had available. As we look at the second or next generation obesity medications, primarily semaglutide and tirzepatide here, we're bridging that gap between what we can achieve with lifestyle alone versus bariatric surgery. But there's much more than meets the eye as we kind of look at what that means. And as we look at the new and emerging therapies, this is the one that everyone's excited about. These are top-line data for retatrutide, triple agonist, glucagon, GLP-1, and GIP, that shows average weight reduction of close to 29% on average with, and if I think it's more insightful if we look at the categorical weight loss outcomes towards the right here, more than 58% of people are achieving a 25% weight reduction, which is kind of like a bariatric-ish benchmark if we think about it that way. And if we look with 35%, 23% of people are achieving that. And so that's a lot. And if we look at the timeline of 68 weeks, you can imagine what's going on from an intake perspective in order to facilitate a 30% weight reduction in a 68-week period of time. And what kind of advice and care will people get in a clinic or an online chatbot that they're ordering stuff from home that's going to support optimal health outcomes beyond simple weight loss? That's the problem. And I think this is what we need to address as a scientific community of how do we highlight what needs to be done for this. We've talked primarily about weight reduction as the outcome, but there are additional indications for therapies. Semaglutide is approved for cardiovascular risk reduction because of 20% MACE reduction for post-event for secondary prevention. Tirzepatide has an indication for obstructive sleep apnea. It decreases AHI substantially to the point that after a year of treatment, those with moderate to severe sleep apnea, more than 40% of them no longer met criteria for CPAP. And then recent approval of semaglutide for MASH. And so what we've got are a variety of different therapies that are obesity medications that now have different indications for obesity-related complications. But how much of the effect is really related to the actual weight reduction versus medication effect? And this then has implications for deciding or the shared decision making at both an individual level and also a health system level of when do you stop the medicine and how do you identify treatment response? And I think it highlights challenges that we have with regards to appropriate diagnosis, phenotyping, or cardiometabolic description of what's going on in that individual beyond their body mass that I think is not happening at a clinical level throughout primary care and even most academic practices. For what they're worth, when we look at the mediation analysis for what proportion of the effect of certain drugs in certain disease states, for example, for cardiovascular risk reduction, they said that 33% of semaglutide's cardioprotective benefit was explained by reduction in waist circumference as a surrogate for visceral fat reduction. When you look at the correlation for tirzepatide in the middle panel there, you can see that there's a direct correlation between reduction in apnea-hypopnea index and reduction in body weight. And it stands to sense that something mechanical like obstructive sleep apnea would have this relationship. When you look at MASH and people think, well, you're reducing fat in the liver, although there aren't GLP-1 receptors in the liver, so that's a whole nother conversation. What you see is that even people who lost less than 2% of their body weight, 48% of them had resolution in their MASH. And so there's clearly something there that's independent of weight reduction that's happening. So how do we decide if this is working, and how do we decide if to stop it or to escalate treatment? And I think the challenge is a lot of these issues, particularly OSA and MASH, are not being diagnosed in general. And we're not doing baseline assessments to work out the burden of disease. And so to then have an informed decision beyond weight change of, is it safe or appropriate to stop a chronic therapy? And you can tell by my intonation, the use of chronic therapy there, that I think you probably shouldn't. This becomes problematic because the data and the evidence aren't there. When we look at and try to rationalize, well, how do things work? It's easy for us to think about the effects that a GLP-1 or a GIP agent can have on glycemia. These were first used for treating diabetes. And in the 3-year follow-up for people treated with tirzepatide who had prediabetes, what they saw was that 97% of those treated with tirzepatide had normalization of their A1C and their blood glucose, relative to 12.6% of people who progressed to type 2 diabetes in the placebo group. So what we see is significant improvements in glycemia, but it stands to sense that a GIP and a GLP agent would do that. However, when you looked at magnitude of weight change and do the mediation analysis for what it's worth, 55% of the effect was mediated through body weight reduction, and therefore there's a significant proportion of weight loss independent effect there, which stands to sense. But it gets more messy. As we look at discontinuation, which happens for a variety of reasons, cost, coverage, access, adverse effects, changes in healthcare policy, changes in university coverage for employees, for example. Too soon? Too soon. What we see is with unplanned discontinuation, a rapid recurrence in body weight. About 2/3 of the lost weight comes back within a year. And so this is seen on the left with semaglutide in the step 1 extension, on the right in SURMOUNT-4, where they switched to placebo or maintained tirzepatide treatment after 36 weeks of care. We need to acknowledge, though, that we talked about weight loss and weight recurrence, but there is a wide variety of magnitudes of weight change that occur with treatment. And these are magnitude of weight loss with 3 commonly used GLP-1 based therapies. And you can see almost a normal distribution of magnitude of weight loss there. And what you see to the left of the vertical dashed lines, these are non-responders, so people who actually gain some weight with treatment. And I think it's important for us to know and understand. We don't understand. They're not good predictors of who's there. The companies have tried to avoid looking at it in any kind of meaningful way, and you can imagine why. But as of yet, we have not been able to identify demographic or other behavioral indicators of treatment non-response. But there's a lot of variety in terms of what happens. And beyond that, that varies by weight recurrence varies by magnitude of weight loss as well, which makes sense with regards to, you can imagine the tension that occurs within our biologic systems with that magnitude of weight reduction, that you would have commensurate weight recurrence there. But there's a lot that goes into that, because when you then look at real world data and people try to make somewhat biased arguments about these drugs don't work because you stop them and the weight comes back, which we all know how ludicrous that is, because we wouldn't say that about an antihypertensive agent or a PCSK9 inhibitor, yet we say it about a GLP-1. We're treating chronic disease episodically, and surprise, we have recurrence. when you look at analyses like this recently published in the BMJ, where they compared lifestyle modification with GLP-1 use alone, and they stratified by older and newer incretin agents. And so the pink line here is a behavioral program. What they said and what a lot of the commentary in the media was is that not only do GLP-1s not work because people regain weight, but they gain so much more weight than if they'd been on a behavioral program. And I think what this really highlights is the lack of behavioral intervention that goes into GLP-1 prescribing as a co-therapy that would be a useful adjunct here, and how this then gets misrepresented in media and reinforces weight bias and stigma that people just need to get their act together. And I think that's problematic when it comes to assumptions around behavior. It's problematic with use of language of obese people instead of people with obesity. I mean, I think we need to acknowledge that what's here and the limitations of real world data that then support a false narrative, we need to create the science and the data that undo this and reinforce patient-centered care. Because beyond the weight recurrence, there's also recurrence in cardiometabolic risk factors. These are the step 1 extension study data where they discontinued semaglutide, and you can see a rapid uptick in systolic blood pressure, A1C or glycemia, and also inflammation with C-reactive protein that seems to happen even before major changes in body weight. And I think that's important to highlight the weight loss independent effects. But when you stratify also by magnitude of weight recurrence, and these are the SURMOUNT-4 studies, so these are the tirzepatide participants who were on 36 weeks of treatment and then randomized either to placebo or continuing tirzepatide. When you looked at the ones who switched to placebo, who experienced weight recurrence, they did quartiles of weight recurrence, or actually by magnitude of how much weight recurred. The less than 25% is the green dot, and the inverted black triangles, those who regain more than 75% of the weight they lost. I think we see two nice distinct things here. On the left, as we look at blood pressure, you see an early stratification by magnitude of weight recurrence. And so you can see that there's a weight dependent effect on blood pressure going up. But as you look to the right, you see two separate phases. You see almost superimposed lines for two of the groups by kind of 50% weight recurrence, where there's a very rapid uptick. So likely medication direct effect independent of weight change. But then subsequent to that, it starts to stratify out. And I think it's important as we then contextualize, what do we need to follow in people who are no longer taking treatment? What time points and how do we rationalize what does not currently exist in the literature and does not currently exist in clinical practice?
No.
And I think by filling in those voids, we can help to inform clinicians and policymakers and payers of the potential harms. And if we are in a state where we are discontinuing for medical reasons, tolerance, or other things, we need to work out how to best support people. And is it sufficient to do that with lifestyle modification alone, which I think this group is likely interested in? But some of the limitations of this, when we have this abrupt discontinuation of a medication that impacts a lot of health behavior, you end up then with this kind of spiraling confounding, which is, I think, is a very interesting principle where you discontinue the GLP-1, you get a rebound in appetite or appropriate hyperphagia, your weight recurs. And because of the hunger and weight recurrence, you then get changes in health behaviors with regards to food choices, quality, the amount of physical activity you're doing. You get increases in metabolic markers, and then social factors then get amplified in terms of stress, resources, support, and access. And so really this stopping the treatment with GLPs really triggers this cascade of kind of non-random things that really compound the effects. And so as we look at studies like this, you can't just tease it out, this is just medication cessation and withdrawal. We need to acknowledge the complexity of the lived experience that these medications change and how that then recurs and amplifies with abrupt cessation. And so it's complex to tease out what's going on, because what you have is this then biologic boomerang, because you have this multimodal control that we don't fully understand and have not been able to tease out. We talked about some of the limitations of the mechanistic work that's currently ongoing and the challenges of how to tease out what's there, because it's not just the number on the scale, it's multi-organ systems are being affected, and you get magnified harm by stopping these agents. In addition to what's the role of these for secondary prevention for often complications that remain undiagnosed. So many of my patients will have lacunar infarcts on head imaging and things that no one ever picked up on and didn't realize how high risk they are for cardiovascular disease. But then by framing this of you just need to try harder, you're really amplifying the weight stigma and bias component of, well, you got your head start with the medicine. Now let's see what you can do with your lifestyle because you've been given a chance. And that is so toxic, but highly prevalent in how things are framed in clinics and health systems. I think this was one of the things at risk of getting fired, and I'm being recorded. So when UT System decided to withdraw access, one of the proponents of fresh food pharmacies lifestyle said, well, we just need to give everyone an electronic scale and some vegetables every week. And they're just going to be able to monitor and keep their weight off by eating healthier and doing better. And I think it's really problematic, even when people within an academic environment have very stigmatizing beliefs around obesity and make assumptions around baseline health behaviors and infer what will then be a solution for people living with obesity. But beyond the biological effects, I think we need to focus in on the quality of life impacts for treatment, but also discontinuation that really aren't very well described. So much of what we know from studies are these patient-reported outcomes. Here we have SF36, and this is the SURMOUNT-4 study with the discontinuation of tirzepatide, where there was improvement across the board in these domains. And what this shows is then the decrement in quality of life for those who were switched to placebo and had GLP-1 withdrawal. And you can see across the board, they're worsening not just in pain and physical functioning, but also in mood and other psychosocial outcomes. So this is not just about just the weight and your joints might ache if you put up another 20 pounds. This is wide-reaching quality of life impacts for people who are living with a chronic disease. And it almost seems unethical when we think about how we would approach other disease systems to then say, well, we can just do this. But in the absence of robust research to inform policy making, we're going to encounter stigmatizing decisions that are made purely based on economics, as many coverage decisions, such as the one here, were likely made on. And so we really don't know if we need to, who we can taper safely, how we should taper, what kind of lifestyle and other supports are needed, how do we even define success in obesity care, and what predicts durability. So these are all questions I'd love for you to answer in the next 12 months, please. And so when you look at it, well, what do we know about risk and harm? We really don't have good data from clinical trials. So the SELECT trial was a cardiovascular outcomes trial, 17,500 people randomized to semaglutide versus placebo, 20% reduction in 3-point MACE for those treated with semaglutide. After 4 years-ish, they demonstrated the utility of semaglutide. And then what they've tried to do is this is the SELECT Life follow-up. And so they're following people with questionnaires for self-reported adverse outcomes, development of diabetes, cardiovascular events, to see, well, is there a legacy effect or what's going on? So far with this recent kind of poster that was, I think, at AHA last year, they had about 20% of people answered their questionnaire to see how they were doing at 18 months out. And really, there's not kind of too much going on. Things aren't separating very much. But that's to say, this is the quality of the data that we currently have and how this is being assessed. And this is really going to be inadequate to appropriately assess the benefits of treatment or potential harm of discontinuation when we know the benefit. What's worrisome is that there are a lot of companies that also publish data with regards to, we have this plan, and when people buy into our program, we can get them off GLPs and save you money. And they then market this to pharmacy benefits managers, to employer health system, including the one I work for, to say, you don't need to spend money on GLP-1s, you can just take people off. And so what this company showed was a retrospective review of people who they convinced to discontinue GLP-1 and be adherent to a ketogenic diet for 12 months. Like, I'm not sure what your success has been like in any of your studies, but trying to get a patient in the real world to adhere to a ketogenic diet for more than a few meals is very challenging, and this is the real world. And so for this to be used by people at my institution to say, we just need a keto diet program to get people off their semaglutide was very problematic for me, as you can imagine. But all that to say is data like these are then presented to policymakers as justification that interventions such as ketogenic diet are both effective and acceptable alternatives to GLP-1 based therapies based solely upon retrospective reviews and using weight loss as the sole outcome to drive the decision making. Beyond that, there are questions about, can we taper off? Because that was abrupt kind of withdrawal. What can we do about tapering? Let's have a tapering program. And this is another thing that many employers are buying into. It's, you're going to be on a GLP-1, you have a lifetime cap of $20,000 or 2 years of treatment, which many, unfortunately, university systems have adopted across the US. And after that, you're going to sign up for one of these tapering programs. And what I want to highlight is a few things. And so there were supposed to be 350 adults going on a 9-week sema taper. Of the 85 participants who tapered off, and they had data at 26 weeks, they had a somewhat stable weight. You could even say it was 1.5 below where they were at when they started to taper. So something is very different about the small subset of the group. But if you look at the paragraph below that, of 46 who tapered off and restarted, the mean weight regain at the time they restarted was only 1.3%. And what this speaks to indirectly is likely the quality of life changes that occur independent to weight gain, likely around symptoms of obesity, food noise, and distress that people are addressing and dealing with. And so to say that, well, if they keep the weight off, everything is just fine, drink some water, go to bed. This is not the way in which we do patient-centered care that engages people for chronic disease management. And so these are, unfortunately, some of the more robust data that exist, which are really terrible. And so there's a lot of opportunity there, because even though we know that lifestyle modification is effective and there's a dose-response relationship, we know that it is not durable, and people with severe obesity or taking obesity medications have likely tried this. It is ludicrous to suggest to someone who's lived with obesity and has been successful with GLP-1 that, have you thought about eating less? Do you think you could walk 30 minutes 5 days a week? I mean, this kind of house wine approach of you should put half your food in a to-go box when your entree arrives, and this is going to fix your weight challenge, is really problematic, but it is what almost all the internal medicine residents tell me is their primary approach to dietary counseling in their primary care practices, because that's what's perpetuated by their attendings in the clinic. And I think it just goes to show that what we are providing our trainees in terms of knowledge base, how they are executing that in the clinic with lack of access to registered dietitians and collaboration is very problematic for patient care. And many will say, well, is the juice worth the squeeze even? And so when you look at GLP-1 trials and the standard intervention, or had been until recently, for example, in the semaglutide trials, where there's a 500 calorie per day deficit, 150 minutes per week of moderate to intense physical activity, and every 4 weeks you meet with a trained behaviorist, we know what the results are. That's the top panel. Step 3 was an intensive one where there was about 1,000 to 1,200 calories per day, meal replacements, followed by a more severe restriction of calories with potential for meal replacements, with up to 200 minutes per week, and then 30 visits with an intensivist. When you look at the average weight reduction category, there's not that huge difference. And so this, unfortunately, has been used by many to say, well, the actual costs and to operationalize what happened in step 3, most health systems and academic centers can't afford to do. Insurance is not going to pay for it. So why do that if the weight loss outcomes are no better? And you hear what I'm saying. What exists there that we are extrapolating from protocols of phase 3 clinical trials that are being done for regulatory purposes is not appropriate data for making decisions around what kind of lifestyle interventions are needed by people with obesity who are receiving care. But unfortunately, it's the most rigorous of what we have done. When we even think about the mechanics of what happens, and so these are data from SURMOUNT-1, tirzepatide, 3 different doses, 5, 10, and 15. And we look at the magnitude of weight change that occurs, the vast majority of it, typically 2/3, is occurring during the dose escalation phase. And so this is a very dynamic thing where typically according to protocols or the older protocols, forced titration every 4 weeks, 2.5 milligrams here, during which time people lose about 2/3 of the weight that they're gonna lose. And when you look at kind of modeling of what does that mean from a calorie intake perspective, and granted, this is only 10 milligrams of tirzepatide and 2.4 of sema, we're looking at a calorie deficit of about 1,000 calories per day or more. There was some CagriSema data for the new co-formulated thing that suggested an 1,800 calorie per day reduction during dose titration, likely for a variety of different reasons and GI adverse effects. And so if you imagine you have the average US adult living with obesity, and we're aware of what the nutrition and dietary quality is, they receive zero education or counseling, anticipatory or otherwise, with regards to what they should do. And they start this medication where they decrease their intake by this magnitude. What do you think their risk for malnutrition, adverse body composition outcomes are going to be? Not just muscle, but bone. And I think this is something, again, that has not been well described. The pharma companies have DEXA data for lean mass and for adipose mass, but they don't have or have chosen not to obtain bone and other things. And I think that's really problematic when the key demographic for treatment is perimenopausal women. What are we doing that's maybe putting them at risk? There's been a kind of evolution in terms of how protocols are being written, particularly for retatrutide. So we kind of showed earlier around 30% weight reduction with these medications. So you can imagine the magnitude of kind of calorie deficit that's occurring to facilitate this. They've changed it from that 500 calorie deficit to dietary counseling that's focusing on healthy diet content rather than restriction and following a balanced diet of nutrient-rich foods. And so again, this makes sense to us, but we don't have good data to support what this really needs to look like. These are great high-level descriptors of something that sounds good, but what does this actually mean, and how do we balance this out for the diversity of people living with obesity, but this also the sub-indications that this is being treated for? GLP-1s are approved for people with CKD to prevent progression, people who have inherent frailty because they've had an MI or a stroke. What does this need to look like for someone on ESR with ESRD who's awaiting a kidney transplant? What's their protein intake, right? And I think this is really problematic when we don't have good data the way that we have that have created guidelines for things like bariatric surgery. So these are the recommendations with regards to education and screening for an intervention. And I'm not trying to conflate surgical malnutrition and anatomical changes with pharmacologic weight loss. But if I'm allowed to also conflate magnitude of weight change for a second and say, well, if they're losing bariatric range weight and they have that degree of malnutrition that's iatrogenic, shouldn't we be thinking about this? And people in the space say, well, you're just creating barriers to access and care. You're going to make everyone do nutrition screening and see a dietitian as if they were having bariatric surgery before you give them this medicine. Why would you do that? And so there's a tension then between access to care and safety that unless we demonstrate potential harm, we're not going to get any buy-in, both from the clinicians who are on the front line or the people who are paying for it. So again, these are gaps in the literature with regards to nutrition risk and other factors for people, especially as they are going to be starting medications that are helping them to lose in excess of 25% of their body weight. In order to try and address these, many of us have tried to put together guidance with regards to how people may approach nutrition factors, understanding that there's a diversity of people. But the challenge even with some of these that we came up with, these are very loose kind of recommendations for primary care clinicians. It's really challenging when you look at this statically. And so I talked about how during the dose escalation phase, there's a dramatic decrease in calorie intake, likely related to changes in not just appetite and satiety, but also GI AEs. And when talking with patients and participants on these treatments, within the first 48 hours, there's an undulation in symptoms. But we create static recommendations for intake and guidance that really don't reflect real world needs with regards to, well, should we be doing like a protein shake, something for the first few days or during titration? Should we try different things? How do we even identify this? And the challenge is that at baseline, the vast majority of patients who are starting treatment are not getting any kind of history taking from their clinician to find out, what are you doing now? And how do we facilitate even an incremental change rather than a prescriptive, everyone on this treatment should do this in a static way? Because that's unfortunately what we ended up creating for simplicity. But what we need is something for practicality and for the real world. And that's really missing. when we look at, well, how can we use lifestyle for weight maintenance? This is something that's really tricky again, because we don't have great data. Bariatric surgery is a really poor model to use as an analogy, because what you have is a permanent intervention to anatomy that you're not stopping. And I think this is really challenging when people try to use bariatric models as a GLP-1 cessation model, because they're like, well, it's kind of similar because they lose as much weight. I'm like, yeah, but they still have the surgery. And so they still have mechanical restriction, whatever other neurohormonal changes that are helping to support the lower body weight. And so even though they'll say, well, the usual thing, doesn't matter about macronutrients, blah, blah, blah. We've all seen papers like this, but we need to avoid using models that are not appropriate for comparing GLP-1 effects. And I think this is an issue that we have, because then people will then cart out, well, those in the National Weight Control Registry who maintain more than 30-pound weight loss, these are the health behaviors. Therefore, if only we got people to do these behaviors, we could stop them from regaining weight. This is also really problematic, because what you're doing is you're taking a cohort of people who declare that they are different because they can lose and maintain 30 pounds without GLP-1s. And you're now trying to reverse engineer an intervention for people who needed, and I hate to say needed like it's pejorative, but required the use or support of pharmacotherapy to achieve the same magnitude of change. And so what we need to do is stop perpetuating this, where we go back to older literature and say, well, this has already been answered. We don't need to fund this, or we don't need this study. This has not been answered in this population. And we need to avoid perpetuating what's currently being done in the literature and in the guidelines as low quality evidence. Some of the other challenges we have around the body composition changes, regardless of whether people lose weight through restrictive dieting without exercise or bariatric surgery or GLP-1s, between 1/4 and 40% of what they lose is non-adipose mass. And this is something that has become hugely clickbaitable by many of my patients, to the point that I will have patients coming in, BMI 50, A1C of 12, and like, my PCP won't get off my back about this GLP-1, but I don't want to lose my muscle mass. And you're like, where are your priorities here? And I think it becomes really challenging when this becomes the red flag for people, that all of a sudden, because their body composition will change in this way, that's presented in this way by influences and others, that this will translate into falls, fracture, frailty. I won't be able to put up my rollerboard in the overhead. I mean, it's very interesting things that people value, that they are worried that will change at an individual level. To kind of counteract that, there've been a lot of post hoc analyses of the body comp or the DEXA sub-studies within some of these trials. These are from SURMOUNT-1, so the tirzepatide trial. And what this shows are kind of changes in body composition. Again, about 25% is lean mass. And what they tried to do is, well, who are you most worried about, clinicians? We're like, well, older people, frailty, that kind of thing. And so you then get a post hoc analysis that looks like this, that says, well, if we look at the left-hand panel here and you kind of look at the body comp changes for those over 65, or the right, the kind of changes in lean mass relative to other age groups, it's about the same percentage reduction, but we're not accounting for age-related loss of lean mass, and we're not accounting for function. And I think this is where we then get false reassurance that, well, it's no different across age groups. What was their starting point, right? What was their function like? And this is not being appropriately assessed either at baseline or as part of routine clinical care for people receiving these therapies. And again, another huge gap in what we need to do. Because even if we try to rationalize, well, if 1/4 to 40% is non-adipose mass, that still means the majority is. And so if I have someone at baseline who was 48% fat mass, and at the end of the clinical trial, they're 40%, that's an improvement in lean mass. So they win, right? And then well, what about absolute? So, but didn't they still lose 6 kilos of lean mass or muscle? Isn't that important? But is it? And we don't have the data that says that it is or isn't. Unless we do, people will either fearmonger and avoid treatment, or they will be excessively worried. And I'm not sure what your social media looks like, but everything from protein sodas to all the way through right now, everyone is just in a state of fear that they're not getting enough protein, and that will in itself fix everything, right? And I think that's really problematic when we're not assessing function, framing interventions as needing to be holistic and multifaceted, not vilifying just one thing or saying that this one thing will fix everything, looking at the integration of physical activity but how we assess then the function as part of that's really important. And the challenge is the literature on this in GLP-1 is even worse. And people will quote studies like this, which are not here to serve that purpose. So this was a VLCD where people lost about 13% body weight and were then randomized to liraglutide exercise or exercise and liraglutide. And this has been used a lot to talk about the role of exercise in people on GLP-1s, when really the weight reduction was initially VLCD, and what they were looking at was weight maintenance and body comp changes for people according to what was going to be a maintenance strategy. I think what's more interesting is when we look at the kind of post-discontinuation of the interventions. And so if we look at the left panel here, at 52 weeks, this is when they stop treatment. And then you can see the weight recurrence curves that occur here. And those who did the exercise and lira combination, unsurprisingly, regained the least amount of weight. And so this in itself kind of says, well, for people who are stopping treatment, there is a role of exercise here, but it really doesn't answer the question of exercise or physical activity as a co-therapy, what the benefits are, or what needs to be done in terms of dose or intensity. And so there are huge gaps here, but it doesn't stop people from misquoting or misinterpreting what is available that's usually industry sponsored and meant to kind of serve a different purpose than creating evidence-based guidelines. There's a lot of modeling that happens all the time with regards to what the potential roles are for body composition changes, but there's no actual data that will support any of this. And again, even less data with regards to how you help someone with severe obesity and mobility and other limitations to achieve what somebody who meets criteria for a phase 3 clinical trial who can do all these things and doesn't have the limitations. And I think that's the challenge. It's how do we create graded activity for baseline functional levels that are really what exists. I would say about 10% of the patients I initially see in clinic are coming in a wheelchair. They are not walking into my clinic. Maybe 5% will be on oxygen 24/7. And I think we need to be mindful that these are the people who likely need the most help and who are at most risk for treatment misadventure. And as we look at kind of next chapters, well, we don't need we can just fix that. I mean, we could use bimagrumab, right? We can just manipulate other systems within the body to either promote growth of lean mass or attenuate the loss. And I think the problem, and so when we look at the study, these are phase 2 results from the BELIEVE trial, which looked at bimagrumab by itself, semaglutide by itself, or combination of bimagrumab with semaglutide. Oh, it works on the myostatin system basically to promote kind of skeletal muscle and or decrease or attenuate loss. And so initially developed, I think, for muscular dystrophy, subsequently abandoned in that space, and then repurposed because of preclinical models showing improvements in body composition and also for glycemia. So the thought is, well, if everyone's worried about loss of lean mass, well, let's just throw something in that's going to attenuate that. So as we kind of look, we can see robust weight loss, 22% for those on the combination of semaglutide and bimagrumab at the higher doses. If we look at the right-hand side, this is percent change in lean mass. So for those on bimagrumab only, so that's for muscle increase, you can see that there's an increase in lean mass. That's what we would expect. Sema only, that's the green bars. You can see that's the greatest reduction in lean mass, and then graded combinations of Sema and Bima with attenuation of lean mass loss. But again, we're now in a place where we are attenuating lean mass with function and metabolic health in a way that we don't have great data for. And how do we mechanistically tease apart what is the effect of semaglutide versus Bima, but also acknowledging that this has now been traded and it's now being combined with tirzepatide, not semaglutide. And so there's a lot of movement in this area. And so hopefully we will see some other results with regards to what's next. And so, but beyond that, I think it's important to acknowledge that when you have agents like this, beyond impacting muscle mass, which is really what people were interested in because it fits likely a commercial narrative that people buy into, is what are the metabolic effects? And there's potential for improvement in utilization and disposal that can be metabolically beneficial. And so again, I don't mean to trash talk it because it likely will have some benefit, but I think we need to work out what are our metrics for measuring success in this space. And so ultimately, just to kind of highlight that there's a lot of role and importance for lifestyle that is currently unaddressed because of the energy intake, changing body composition, adverse weight, and we know that lifestyle supports that, but we don't know what lifestyle and for whom. Rapid weight loss and hunger reduction require intentional nutritional guidance that's really not occurring in the vast majority of people who are taking these medications. And physical activity patterns vary a lot based on people's baseline function. And we need to work out what is optimal, not just for lean mass, but for bone and overall cardio kidney metabolic benefits. But really the kind of the behavioral and mental health aspect of this is something that is grossly overlooked, likely because historically it's been quite stigmatizing in terms of you just need group support to get your act together, that a lot of people really do not respond well to because they've been either, I think, Weight Watchers to death, where they're like, I've been doing group kind of behavioral programs for decades, and this is the only thing that's worked for me. So to convince them, well, you just need to go back, they're like, you're not listening. And I think that that's a huge issue when patients don't feel that you are validating their concerns. I think it's validating that many organizations are getting behind the adjunctive role of lifestyle. Even the WHO, this was a total surprise. The WHO is weighing in on the role of lifestyle in GLP-1 use, but it's validation where they're saying that these are chronic therapies that are helpful for health and that people should have access to treatments in addition to access to comprehensive patient-centered lifestyle support. But no one knows what that looks like. And again, we keep extrapolating from clinical trials that aren't designed to assess the impact. And so as we look at these different levers for people who are on medication, tapering, and off, we really need to work out how do we manipulate or provide the right kind of balance for nutrition advice. If we are tapering people off, how do we do that in a structured way? How do we get people off medication, if that's even the right thing to do, which it really isn't. And I think even from a clinical trial design perspective, as you're thinking through, well, what does this look like if this is a deprescribing type space? We don't even have good taper and transition. In the real world clinical practice, because of cost and utilization, you may have colleagues and friends who've lost coverage for medications like, well, I still have a stash, but I'm just going to take half a dose and maybe every 10 days or every 14 days, or if I feel hungry. That is really not evidence-based and probably not, I won't say it's not safe, but it's probably not going to support long-term health. So we really need, for people who need to discontinue or taper, we need better guidance with regards to what that needs to look like. I think trials definitely need built-in kind of continuation or extension to look at long-term effects of this. Patients need better communication and consent when it comes to clinical trials. I have so many patients who have been in clinical trials who feel that they have been abandoned by the system. And not that it is a pharmaceutical company's duty to deliver chronic disease management care. I believe that is upon society, and for a variety of different reasons, we won't talk about politics. But that being said, I think people who are participating in trials with you who are going to receive life-altering treatments need to understand what could happen if they no longer have access following cessation of that. And we need to make sure when we are consenting and approaching people living with obesity that we use appropriate patient-first and respectful language and not make assumptions about their health behaviors and their lifestyle based on their BMI alone. And developing structured patient support programs that incorporate nutrition and lifestyle are really key to how we support people following cessation in different trials. Because at the end of the day, this is my summary, that obesity is biological, not behavioral. And really the stigma that many clinicians, researchers, patients, and society carry into this really undermines the care and the things we're ultimately trying to achieve to advance obesity. And so we have a role in sustainable care to provide structure and support and evidence-based strategies, or at least the data for them, that really focus beyond the weight on function and well-being and metabolic health. And I think that's one of the main challenges, that we need data for nutrition and metabolic safety. We need more on muscle function and physical activity, but even more on the behavioral, psychosocial, and care models that actually will deliver these interventions, because that scaffold or framework does not exist in many places, and those who have them are struggling to keep them together because of budgetary and funding and reimbursement constraints, including our own. And that is, I think, something that needs to be done, that how do you demonstrate the value or potential harm? These data are severely lacking. And also, just to kind of put in a plug here, it's how do we kind of reclaim obesity as a legitimate disease that requires appropriate evidence-based medical and scientific care when it's essentially been normalized that you can click an ad on your social media, get taken to a website or download an app, interact with a bot for 3 or 4 sentences, put in your payment details, and then get 6 months worth of medication shipped out to your house. If that's been normalized and you're now seeing a patient for a consult, and you're like, okay, well, we'd like to see you back in 4 weeks, see how you're doing, maybe increase the dose, you're gonna meet with a dietitian again today, they're gonna call you in 2 weeks, see how you do. I just need the script. This is what is now normal for healthcare consumers. And I think we need to normalize the incorporation of legitimate medical, I don't mean monitoring and oversight in a bad way, but collaboration in a meaningful way that incorporates lifestyle in a way that's not currently being done. And the value proposition is not there because we need these models of care that are patient-centered and that incorporate registered dietitians, exercise professionals, mental health, and clinicians who specialize in cardio-kidney metabolic care. And so your last call to action here is that lifestyle is a co-therapy, not an adjunct, a salvage, or an off-ramp. And nutrition activity and behavioral strategies need to be tailored to every phase of care. And we touched on the changes in appetite and other behaviors throughout the course of treatment. We need to be dynamic in how we design and create programs to do that. We need to look beyond lean mass to actual muscle function and prioritize how we can work out what does protein prioritization look like, because it's become kind of a throwaway term right now. You just need to eat more protein. We need to close these gaps with regards to what trial design looks like, what kind of real-world analyses are being done to work out, are there signals that can get the attention of funding agencies and others to help support us in this mission to do what we need to do. We need to make sure that what we're doing is actually patient-centered and not just reframing the lifestyle or stigmatizing experiences that many of them have had, both in research and clinical care around their weight, but ultimately to build the sustainable models that chronic disease management needs in order to focus in on the health gains with or without medications. So with that in mind, thank you so much for your time.
Questions?
If you looked at the DCCT trial, there was a memory effect. Do these drugs have a memory effect too once they are stopped?
And we don't know. We don't have long-term enough data. The Select Life trial, which is again that kind of survey self-reported outcomes thing, is attempting to look at that from a cardiovascular outcomes perspective. But again, it's self-reported. It's only about 20% of people are actually answering the questionnaires. And so we really don't have good data on what that means. Anecdotally, unfortunately, given that the majority of people who have accessed these treatments before, high cardiometabolic risk or burden, and they experience significant weight recurrence, as the clinical trials have shown, but also recurrence in the cardiometabolic risk factors. So I'm not sure that there's much of a legacy effect for the majority of people. 15% of people will maintain their weight off drug with abrupt cessation. But then again, that's conflating weight maintenance with cardiometabolic health maintenance too. And so again, there's an absence of data to support a legacy effect right now for the majority of people.
I want to bounce off. So talking with a dietitian, the easiest way to communicate diet challenges, I want to know what you think. She said protein, water, fiber.
Mm-hmm.
So do you think that captures some of the big challenges?
Is that Michelle? Okay, no, because no, yeah.
Michelle said
that.
And that's pretty much what I say as well, because I think what happens is patients get very overwhelmed by nutrition advice. I mean, God forbid they're also on dialysis and they've seen a dialysis dietitian, they've got heart failure and they've seen the heart failure dietitian, and then they come to us and they're like, so I can eat nothing. And you're like, no, that's not what we're saying. And it becomes incredibly overwhelming. And so we focus in incrementally on, this is not a restrictive pattern, because people will use these agents just to lean into restrictive practices that they've had over decades. And we know that that's not good for psychosocial and also nutritional outcome reasons. And so we really reinforce this is more of a scavenger hunt to make sure your body's getting what it needs. We're going to focus in simply on protein, and we just give it in terms of grams rather than per kilo and confusing things. We talk about fluid, and then fiber, we use more of a fruits and vegetables thing rather than being prescriptive because people don't know how much fiber is there. And I think what's problematic is when you do the fiber phrasing, people are like, well, I'm just going to do these fiber gummies or pills or others. And when you have, right, oh, wow, it's a visceral response, pun intended. And what you have then with the kind of slow GI transit is just more opportunity for fermentation and gas. And for people who are already feeling bloated and full, you pump them full of fermentable fibers, it gets worse. And so we really kind of moved away from promoting fiber for the constipation angle, even though intuitively it's there. We have to do some more fruits and veg, or we do osmotic laxatives like Miralax, because it's just you get a cleaner result, so to speak, and less of the risk for bloating, which I think compounds then a lot of the dyspepsia and nausea that lead to either dose reduction or discontinuation.
First, I just want to thank you for that really nice summary and overview. And I think your goals again were so on point. So hopefully you're screaming that on the rooftops to all of the clinician friends. It's really important. So I'm really interested in this myostatin inhibitor stuff. So I just started learning about these, and I'm wondering like what the side effects are. Do you see that as being like kind of the next things? That's really exciting that they have that lean mass.
It's super exciting, but I think there's some things that we know about them from an adverse effect perspective. Muscle cramping, twitching, and things have been very limiting. There was some at EASD last year.
One study that stopped.
Mm-hmm.
Yes.
Yeah, several because of side effects. So primarily, I mean, patients can't tolerate the kind of the nighttime cramping and twitching. It's problematic and it's dose dependent. Yeah.
Play with it and see if maybe that.
And so that's something that's being looked into as well. So there are a lot of companies that are investigating this, but it's been limited primarily by side effects, and discontinuation rates were really high. So we're hopeful. But again, it's then down to, well, are we conflating lean mass with function and metabolic benefit? And I think we need more robust ways of measuring this. And if we're saying, well, these are for our at-risk populations, for sarcopenia and older adults and everything else, we actually need the trials and the studies to show that. And currently, with most people chasing the money, unfortunately, that we're going for garden variety obesity in people who are 30 to 60 years of age that may not necessarily have the same risks as somebody with more inherent frailty. But still, we need the data in these populations too to work out what are the long-term benefits or harms.
I do have one. What are your thoughts on how discussion related to lifestyle and GLP-1, how can that be integrated into the nutrition education curriculum for medical students that has a huge focus on now? Like a lot of the med schools are now.
Mm-hmm. You know, I think I would say that this is something that's attractive. If you frame a nutrition talk of, we're going to give you some nutrition education to support people on GLP-1s, people pay attention because med students, they are human. And so they're being asked questions by family members and friends all the time about stuff. They have no nutrition knowledge, yet they're the subject matter experts somehow, right? And so I think by framing it as that, you're going to get much more interest. In terms of the question is then how to or what to put in, or
integrate that into the nutrition education curriculum that, you know, a lot of the med schools are not developing for the medical student.
Yeah, I think there's several ways of doing it, whether you do that in kind of the endocrine pharmacotherapy block where you're kind of marrying them together and they see the relevance. It's likely they'll pay much more attention to it versus a standalone. Here's your nutrition block. Here are your vitamin deficiencies you need to know for step one. And also for people on GLP-1s, when they don't even know really how a GLP-1 works, or what the adverse body composition things are because they haven't talked about the pharmacology, it may not be helpful. So I would make sure that the context is going to drive the retention or interest.
Thank you.
Thank you.
Fantastic talk, Jaime. Thank you. What do you think the age cutoff is for recommending these GLP-1s and GIPs? You know, are you prescribing them to 65 and 70-year-olds, or where's the ceiling?
So I think it depends on functional level. I've in the last several months, I've had several 80-plus-year-olds being referred to the clinic. And at first I'm just like, why the heck are these people here? You know, I kind of screening my kind of patient list for the day. I'm just like, 85, what's going on here? And you talk with them. These are, I hate to use terms like good and bad. This is a good 85-year-old who has, you know, a lot of functional ability, independent, has joint pain, some sleep apnea. And so I think it needs to be done on a case-by-case basis. I think to make kind of a blanket, you shouldn't do this, is something that we learned from bariatric surgery as well. The benefits or the lack of safety signal in older adults, provided they pass an initial screening. The issue is, I think we don't have effective ways for most clinicians who don't do this every day to work out, is this a safe individual or not for this intervention, and what additional support an older adult might need. For those individuals, we see them back every 4 weeks during dose titration. We make sure they're not losing weight too quickly. And the challenge is we don't even have kind of guidelines on what too much weight loss too quickly is. Because I mean, I hate to say, the joke is many older adults, will have the conversation, but, we want to make sure this is nice and slow, 1 to 2 pounds per week. They're like, honey, I'm 84. I'm going to be 100 by the time I get to the weight I want. And then you're like, you got a point. And so it's about that shared decision making, and just the reality of patient care and trust, and that engagement of, I want you to tell me if you're realizing that you're not able to do things that you're able to do now. I want you to make sure that you're getting these things. And when the dietitian says that, he or she wants to meet with you in the next 2 to 4 weeks, you don't ghost them. And I think these are really important real life things, because many of our patients have been in and out of clinics before, like, I saw her in the hospital, I don't need to see her. And you're just like, no. This is part of the program. And so I think it's important for us to have those frank discussions with higher risk individuals, just to make sure. And it's kind of a similar thing like with our organ transplant patients. It's like, oh, there's a risk for dehydration or for a decreased fluid intake. Should someone after kidney transplant get one of these straight out the gate? Do we continue it perioperatively? Do we wait 3 months, wait for a certain graft function? There's a lot that we don't know or understand, that I think we need the data for.
Well, thank you very much.